And hello, welcome to week 6, is it? Yes, it's week 6. Time flies when you're having fun. Today, we're going to talk about the concept of perfusion as it relates to the heart and the circulatory system of the heart. Perfusion of the heart, ironically. So I will dive right in. At any point, if anybody has any questions, please feel free to pipe right up and ask a question. Remember this little guy. Anytime you see him, you might want to remember what he's talking about. Again, we'll begin with the definition of the concept of perfusion. We always start with our concept. I'm going to give you a little quick review of the coronary perfusion of the heart. I know you've already had it. And that video crash course, he does a really good job of talking about the circulatory system of the heart. What we're going to talk about today is going to be coronary artery disease, myocardial infarction, or MI. That's the big one. That's where the guy puts their fist on their chest, their eyes roll back in their head. And that's why you took CPR class. And last but not least, peripheral vascular disease. So remember, perfusion refers to the passage of oxygenated capillary blood through the body's tissues. Don't you love it when people read the slide to you? That's what we've been working with for the next 5 weeks. So you guys probably have that down pat, right? Oh, might see that again. I'm going to move my little box up out of the way here. There we go. Okay, the main vessels of the heart. These are the big guys. Now, when your left ventricle contracts and it shoots blood out here into the aorta before it goes to your body, a little bit of that blood gets squirted back into the heart so that the heart can breathe. The 4 main vessels are the left coronary, or the right coronary artery right here, and then the left coronary artery. And we call these the RCA and the LCA. And I'm mostly just making you familiar with that because you're going to see that term thrown around a lot, especially if you end up working with post-catheterization patients. The doctor will say, well, they had an 80% blockage in their LCA. Okay, well, we know that this vessel over here, Mr. Smith, had a big thrombus in here that plugged up 80% of that vessel. And the catheter lab, they went in there and they blew that out and opened it up again so that his heart can get blood. Now, off of the LCA, we have a circumflex artery that branches off to the individual's left. We call that the circ. You hear that term thrown around. And then there's another vessel that goes down underneath the heart, and this is called the left anterior descending artery, or the LAD. So just 4 basic vessels of the heart, and then it branches off into 1,000 smaller vessels. Now you hear these thrown around a lot. Arterial sclerosis, which sounds like you've got a lisp, arterial sclerosis, and arterial sclerosis. Arterial sclerosis is basically hardening of the arteries. You know, that's when you go to the hamburger, what is it, the heart attack shack in Vegas that has the big hamburgers, and they say, I can feel my arteries hardening. That's what they're talking about, arterial sclerosis. But basically, that's just where the walls of the vessels get hard and they can't expand and contract like they used to. The one that we're mostly going to be concerned about is arterial sclerosis, because that's where you start to get this crap built up inside your vessels. And I apologize, but these illustrations I got from the textbook, some of them are a little fuzzy. I have to complain to Lippincott about that. But you get that crap built up there. And the problem with this is, like, this little piece here could like sever off and then plug right here. And then all of a sudden your artery is plugged and you've got some serious problems. Arterial sclerosis, the calcium is deposited in the vessel And that's what causes the calcium. I mean, that's the same thing as in your bone, right? Causes the vessel to harden up so that it doesn't expand and contract the way it should be. And that can reduce the amount of oxygen going to your body. That's a problem, but that's not what causes heart attacks. Arterial sclerosis, that's when you get that plaque building up in the vessel that breaks free, or it just builds up to the point to where it starts plugging the artery off, and you're not getting enough blood through that vessel. And if it's in the heart, that can cause a heart attack. The other one is kind of more of a hereditary. Arterial sclerosis is more dependent upon our behavior. That's what makes it more modifiable. Oops, went right through the middle of that, didn't I? Meaning, these are the risk factors here. This is what causes us to have arterial sclerosis. Cigarette smoking, stressful lifestyle, obesity, diabetes, hypertension. These are all contributing factors. What is shown in here, diabetes and obesity, it means the diet. The diet is what contributes to arterial sclerosis. High fat diet, high carbohydrate diet, the American diet is what really contributes to arterial sclerosis. And that's one of the reasons why Americans have one of the highest rates of heart disease in the world. You'll hear me talk a lot about diet. That's one of my sticking points. Oh, might want to remember that. Now, when we talk about coronary artery disease is kind of like a blanket term. Anytime we're talking about any diseases of the vessels, but as they apply to the heart, not as they apply to the lungs or the arms or the legs. That's peripheral vascular disease or peripheral artery disease. Coronary artery disease, we're talking about the vessels in the heart, coronary arteries, because without those, you're toast, basically. Coronary artery disease usually happens in men sooner than it does in women. That's why the majority of the heart attacks we see will be male as opposed to female. Therefore, that's one of the genetic factors. Diabetes has a genetic link. If you don't know that, you will know that by the time you get done talking to Eileen. High lipid profile and hypertension also have genetic links. If your father and your brother have high blood pressure, you probably will have high blood pressure. And it will be also difficult for you to keep your lipid levels down as well. So these are all genetic factors. But then there's also environmental factors like we just talked about: smoking, obesity, sedentary lifestyle, high fat diet. And there's that diet again. Now, when it comes to coronary artery disease, you can have just mild buildup in your vessels, and you may not even know it. I mean, most of us, when you get over 60, you got to start getting some buildup in your heart. There's just no way around it. It's called aging, or what we used to refer to in the ER as TMB, too many birthdays. If you have a more severe case of coronary artery disease, the plaque is building up in the vessel, and it's really restricting the amount of blood getting to those little vessels in your heart. And then you can start getting some actual symptoms. And those symptoms is usually what we call angina. Now, angina is not the same as a heart attack. In a heart attack, your vessel plugs up and you're in trouble. Angina, it's just kind of restricting the amount of blood getting to your heart. And that can cause the heart to kind of spasm a little bit. And when it does, you're getting angina. Now, these are the people you see walking around with a little tiny container with the nitroglycerin tablets. And they go, oh, and they take a nitroglycerin tablet and they pop it under their tongue, and then the pain goes away. Now, that's just something just people basically live with. If it gets really bad, then they take them into the cath lab and they open those vessels up. But for the most part, they just give them some nitro. And then when it gets really bad, then they take them in for a surgical intervention. Now, this is, I want to point out here, angina and the narrowing of the vessels and stuff results in myocardial ischemia, impaired oxygenation, as opposed to a myocardial infarction. Infarction is a complete blockage. Ischemia is just where it's kind of restricting the amount of oxygen getting to your heart. So you get those two terms there that you'll be exposed to: ischemia versus infarction. Now, myocardial ischemia is not a heart attack. That is just the angina. And normally these guys with the little tablets, they'll take they'll take a tablet, wait 5 minutes, see if the pain goes away. Take a second one, wait 5 minutes, see if the pain goes away. And then they take a third one. Now, after they take the third one and wait 5 minutes, if that pain doesn't go away, then they call 911 and they go to the hospital. And that's where you have like this kind of angina is kind of controlled angina, so to speak. And if the nitroglycerin doesn't fix the problem, that's when they have to start looking at other measures. Now, I wanted to point this out. In most males, when they start having any ischemia of the heart or restriction of blood flow in the heart, this is what it's going to manifest as. They may have a little epigastric discomfort. They'll think they have heartburn. And that's why when somebody walks in the emergency room and is an older gentleman, say 65 years old, and says, I feel like I've got heartburn. One thing we used to do is we used to give them some Mylanta with viscous lidocaine and have them drink it. And that numbs the esophagus. So if it really was heartburn or GERDs, the pain would go away. But at the same time, we're also taking their blood and we're doing an EKG because that could indicate they're having a heart attack. The classic sign is right hand over left chest, like they're saying the Pledge of Allegiance. The pain shoots down the left arm, shoots up into the left jaw, and they feel like there's an elephant sitting on their chest. Now that is classic heart attack signs. It might radiate to the back as well. And depending on what vessel of the heart is being blocked, you might get something a little different, like might get some pain down the right side. But I'll talk about that here in a minute. Any questions on what I've covered so far? Clear as mud, right? Okay, we're moving on. Diagnostic and labs. High lipid profile will indicate that a person is at risk for arterial sclerosis. It doesn't tell us if they have it. It just tells us they're at risk at it. And even an EKG will not tell us if a person has a lot of buildup in the heart. The only way to know for sure how much buildup of plaque is in the heart is to have a catheterization. And that process is way too expensive for us to use it as a diagnostic tool. I will give you an example. I had a friend of mine who was retired, and he went to the doctor. He had his blood tested. He had a stress test, which is an EKG while you're on a treadmill. And the doctor said he had a 25-year-old heart. About 6 months later, he had chest pain and went to the hospital, and they wound up doing open heart surgery on him and bypassing 5 vessels in his heart. And so from that day on, I continued to tease him and say, boy, I don't know what 25-year-old they were talking about for you, but I hope that's not the same 25-year-old that I've got. So there's really no way to know for sure how well your vessels are plugged unless we actually put you in a cath lab. And the cath lab is pretty much reserved for those people who are experiencing chest pain. So when it comes to diagnostics, we're kind of limited. Pharmacology. I told you about the nitrates, the nitroglycerin tablet that the gentleman takes. We'll talk more about that. I think we talk more about that in, I think it's week 10 when we talk about surgeries, because there's two types of nitrates. There's what you use out on the street, and there's what we use in the hospital. That gentleman with a little silver vial and a little tablet that goes under their tongue, that's the nitroglycerin tablets, or I think they call it nitrostat on the street. That's what he takes. But also in the hospital, we have big glass bottles of nitroglycerin. Now, don't worry, if you drop it, it doesn't explode. The nitroglycerin comes in glass bottles because it interacts with plastic. So it can't come in the plastic bag like you get normal saline. So when you see a big glass bottle, yeah, it's probably nitro. And what that drug does is it opens up your vessels. And like I said, we'll talk more about that drug later. So this is just more for your own information. But when that guy is having a hard time in his chest and he can't breathe and it hurts and he takes a nitro tablet, the nitro tablet makes his blood vessels open up, giving the heart more oxygen. And that's what makes the pain go away. So that's what we use nitro for. What's more important, and what you might want to look at right now, are the statins. Now, these are just a medication for lowering your cholesterol, lowering the lipids in your bloodstream. And you will see this a lot in the when you start your clinicals. Lipitor. A lot of people get Lipitor. Now, you might have seen a lot in the news lately about statins. Oh, statins have horrible side effects. Should you really be taking them? Blah, 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 blah. Cholesterol has always been very, very controversial. In Europe, they don't think cholesterol is that important. In the United States, we think cholesterol is very important. So there's a lot of controversy around statins. You'll see that in the news a lot. What you have to just remember, though, is statins are for lowering your cholesterol. And another one is antiplatelets. Now, there's a lot of different antiplatelet medications like Plavix and such. The one we mostly use is aspirin. Now, when your doctor says take a baby aspirin every day, he doesn't care if you have a headache. Aspirin has an antiplatelet effect. So what that does is that helps prevent the platelets from building up in your blood vessel. So that's why everybody who has high blood pressure or any kind of cardiac risk at all, they'll pop a baby aspirin every morning or every night, whatever they take. I'm going to quiz you on that because I had nursing students in my clinical class, and I said, why are they taking a baby aspirin? And they said, for pain. I said, no, baby aspirin is not going to do anything for pain. So I'm going to catch you on that. I'll catch somebody on that. Nursing management, ineffective health maintenance. Now they're basically, these are individuals that are at risk. They are not really, they may or may not be manifesting any symptoms at the time. So what you want to do is get those risk factors down. If they're a smoker, stop smoking. Watch your diet, exercise, everything they tell people with high cholesterol or high blood pressure. Reduce the risk factors and you'll have a healthier life. Hopefully keep you from winding up in the cath lab. And knowledge deficit. I've always contended that probably 50% of our job as a nurse is being a teacher. We have to educate our patients. We want them, the two things we really have to educate them on. One, their disease. We have to educate them so that they can help control the disease through natural means if they can. Second is pharmacology. We're giving them a bunch of medicines. They're going to say, what is this red pill for? We have to be able to explain to them what that red pill is, why we're giving it to them. So we are teachers. We don't just run around popping IVs in people. Okay. Any questions on cardiovascular disease before I move into the big guy? Any questions? Nope. So either I'm explaining this very well or you're all asleep, one of the two. Okay. Myocardial infarction, MI. This is the biggie. For those of you who are old enough to remember, I'm coming to see you, Elizabeth. Nah, nobody's going to remember that show. Anyway, this happens when you actually get an occlusion of the artery in the heart. And there again, we're talking about our arterial and arteriosclerotic changes in the vessel, mostly arteriosclerosis, because remember, that's where the plaque builds up. This is what you went to CPR class for. Here's a good example. And again, the slide is fuzzy. I don't know why they put a fuzzy slide in there, but here are some classic areas where you will see blockages occur. Now, here's the left anterior descending artery. Remember the LAD. If that gets blocked, it blocks off the anterior wall. And the reason that this chart is important, not so much for you right now, but if you do, any of you want to go into cardiac and like do cardiac ICU and things like that, you will be looking at, was it an anterior wall MI? Was it a lateral wall MI? Was it an inferior wall MI? Now, these are areas of the heart, the septal wall, the posterior wall. Those areas are affected by different vessels. So for example, if at the very distal end of the right coronary artery, the RCA, if you get a blockage, you're going to have an inferior wall MI. Now, the reason this is important is because when we do an ECG or an EKG on a person, the electrical current is going to show us what area of the heart was affected. So when we get to the lead, for example, leads 2, 3, and 7, they have an elevated ST wave, and you'll learn all about that in the future. Okay, that indicates an inferior wall MI. So we know because of the ECG that this is the area that got damaged. Now, what that tells the doctor is, okay, I have to look at the RCA when I go to the cath lab because that's what's blocked. And so that's where the ECG comes in really handy, is it tells that the electrical pattern through the heart shows us where the damaged area of the heart is. And if you get into, you go to ACLS class and get into the heart and catheterizations and stuff, you'll learn all about this stuff. I'm not expecting you to know these right now. Okay, MI, how does it manifest? In men, it's usually that fist over the chest, left shoulder, left arm, teeth, jaw, throat, this whole area here. And if they're just having pain, that's time to get them to the hospital like right now. And that's usually indicate that a vessel is getting blocked, but is not totally blocked yet. Or it's a small vessel that's being blocked and not a big vessel. If somebody's whole vessel, like an LAD or an RCA, plugs up all of a sudden, that's when you see the eyes roll back in the head, boom, they fall down and you're doing CPR on them. So, I mean, that's why chest pain is so important for us to take seriously in a hospital. Women are different. Women don't do the hand over the chest. For some reason, they are anatomically different when it comes to the heart. And you never know what indicates a heart attack. Combining that with the fact that women have less heart attacks than men, it's prone to let us not detect cardiac problems in women as well as we can in men. For example, most of the women that I've seen come into the ER who are having a heart attack complain of gastric upset. They think there's something wrong with their tummy. So I got used in the ER when a 60 or 70-year-old lady came in complaining of stomach pain. The first thing I would do is put her on an ECG and see if there's any changes in her ECG. That's just the way they're put together. I don't know why. Nature's funny. Now, when we're talking about angina, the vessel partially blocked, usually nitro and rest will make the pain go away. But if that pain continues for a long period of time, or if the 3 nitros don't do the trick, they may be having an MI and not just angina. And most of the guys who have angina have been through this 1,000 times, so they know when something's wrong. If a guy walks in and says, I took 3 nitros, the pain's not going away, you got a serious problem. Now there again, that's the same chart, but I guess I wanted to point out that like epigastrium is very common in women when they're having an MI. So that little old lady in the skilled nursing center, when she starts saying, oh, my stomach hurts, yeah, you might want to check some things out. Now, when somebody does have a cardiac event, what happens is the blood vessel plugs up in the heart and the tissue that's downstream from that vessel begins to die, goes ischemic. If that muscle tissue begins to die, the cells will release enzymes into the bloodstream. And these enzymes are the creatine kinase, or CK, and CKMB. Now, CK is every muscle in your body has creatine kinase. So if you're a big time weightlifter and you're damaging your muscles by lifting weights, you might have a high CK, but it's got nothing to do with your heart. So it's not the most reliable marker for heart. Now, CKMB is more specific to the smooth muscle of the heart. So that's a little more specific to the heart muscle. But the gold standard that we use in the hospital is troponin. Troponin is strictly the cardiac muscle. And most of us, it's well below 0.1 on our scale. And if we ever see the troponin elevate, it's a good indication they're having a heart attack. Combine that with an ECG. And the important thing to remember is ECG just traces the electrical pathway of the heart. Next week, we'll talk a lot about that. Next week, when we talk about the electrical activity of the heart, we're going to show how the ECG shows the different areas of the heart. And you're also going to learn how to read cardiac strips next week. The important thing to remember is this electrical activity shows us where the area of the heart is damaged. So if someone walks in and they have an elevated troponin and they have EKG changes, usually the first thing we do is we race them to the cath lab. And the sooner the better, because the longer we wait, the more heart muscle dies. Remember, all the ECG shows is the electrical activity of the heart. It doesn't show anything else. Now, sometimes what we can do is we can do thrombolytic therapy. There is a drug called thrombolytic plasminogen activator, or we commonly call it TPA. TPA, we also call the clot buster. That's a drug that we can inject into a patient. And hopefully this is a very strong anti-thrombolytic drug. What it does is it breaks down the plaque in your vessels and hopefully breaks up that clot, and you start getting more blood to your body and you feel better. There are risks with the clot buster because if you're prone to bleed, we are basically reducing your clotting function through your whole body. If you have a tiny leak in your brain or in another organ of your body, it's going to bleed profusely. And that's why we have to do this big, long survey on an individual before we do TPA on them, saying, have you had any surgery? Do you have any blood clotting problems? One they don't have on, but they should have is, are you alcoholic? Because alcoholics, it impacts their liver, and their liver helps with their clotting factors, and drunks have a tendency to bleed a lot. I've had 2 bleed outs in the ICU and they were both alcoholics. So anything that affects your clotting in your body, have you been on warfarin or Coumadin? We can't give them the clot buster. So it's not the best treatment. It's there, it's available if we need it. But the best treatment by far is race them to the cath lab, cardiac angiogram. And we will talk about that in week 10. But the cardiac angiogram, basically, we run a catheter up into their heart and we break up that clot. They also used to call it a balloon angiogram because we actually take and the catheter goes into the vessel and blows up like a balloon and pushes all that plaque up against the wall and opens up the vessel and the heart can breathe again. Sometimes they'll use a stent. A stent, if you ever look at one, you know, when you take your ballpoint pen apart and you got that silly little spring in there, that's what a stent looks like. And that goes in there and they band it open and it opens up the vessel so the blood can flow. But we'll talk all about that in week 10. Now, if they get in there and those vessels are just crap and they can't get the catheter through it, it's so plugged up, then they race them from the cath lab over to surgery and they do a coronary artery bypass graft. And this is open heart surgery. They actually open up the chest and they take veins from your leg or your arm and they splice them into your heart so the blood can bypass the blockage. And we'll talk about that in week 10. There's special considerations when it comes to taking care of post-cath patients and post open heart surgery. Coronary artery bypass graft, we call it CABG, C-A-B-G. So you'll hear them talk around the hospital, oh, he had a CABG. And then they may say CABG times 2, CABG times 3. That's the number of vessels that they bypassed. Like I was telling you about my friend, they had the heart of a 25-year-old. He had a CABG times 5, which is really unusual. Usually it's 2 or 3. He had 5 vessels bypassed. He was a mess. But he smoked, he ate like crap, you know. I was not surprised. Anyway, I digress. So that's what clot busters is, thrombolytic therapy. Acute pain with impaired oxygen. Oh, nursing management. I forgot where I was there for a minute. Acute pain. Now, this pain is being caused by the heart not getting enough oxygen. So, of course, if you increase the oxygen level in the blood of the individual, it will relieve some of the pain. And this is why I'm trying to remember the abbreviation we use in ACLS, but one of the first things we do with a cardiac patient on scene is give them oxygen. We want to get as much oxygen to that heart as we can to keep tissue from dying. There are several things. There's 4 things we do with the patient. I was a paramedic at one point too, and there's 4 things we always do. We give them an aspirin to get that antiplatelet effect going. We give them oxygen. I said 4 and I just forgot what one of them was. Anyway, baby aspirin, nitroglycerin. Oh, baby aspirin, nitroglycerin, oxygen. And the 4th one is morphine. Now, morphine, as you know, is an opiate and it helps relieve pain. And that is all good. But an added side effect of morphine is it helps the heart to breathe better. It helps the oxygenation of the heart. And that's why when it comes to chest pain, we don't give them oxycodone or hydrocodone or anything else. We give them pure morphine. Morphine is the standard for heart attacks. Also, other things you'll have to consider as a nurse, anxiety and fear. You think, I mean, this person thinks they're dying. So you definitely have to pull out your therapeutic communication and work with them and assure them that we are doing everything we can to help them. And anything you can do to help them relax helps, because stress is going to make the heart work harder. It works harder. It's going to use more oxygen, uses more oxygen. It's going to hurt more. So the more they can relax, the better. And then post-surgical considerations, which we'll talk about in week 10. Oxygen, nitroglycerin, morphine, aspirin. I don't have aspirin on there. I should add it. But remember those things. They used to have a term for it. Morphine, oxygen, aspirin, nitro. Moan. That's what we use. MOAN. Moan. I don't know. It's been a while since I was a paramedic. Pharmacologically speaking, once the person is in the hospital, remember at home, we'd give them warfarin, we give them aspirin. Once they get in the hospital, though, we can give them heparin, straight heparin, IV. That's usually restricted to the ER and to the ICU units because you have to monitor it very closely, very closely. You're taking PTTs like every hour, every 2 hours. Once they go home, we can put them on an anticoagulant like warfarin. Warfarin is strong stuff, warfarin, Coumadin, and it also requires that you get an INR. Usually once or twice a week, you'll be going in for a blood test, and this INR test lets us know if the warfarin is in therapeutic range. You know, INR should always, for somebody who is on warfarin, for you and I, our INR is low. It's like maybe 1. For somebody on warfarin, their INR should be 2 to 3. 2 to 3 is that magic number. So they're always going in and get their test done. If it's below 2, then we have to increase the dose, or the doctor increases the dose of warfarin. If it's above 3, then they're too anticoagulated, which means they might bleed too easily. So we have to reduce their warfarin. So we adjust the warfarin based on their INR test. It's kind of a pain for people coming in. Fortunately, a couple of years back, they came out with Paxaban or Eliquis. Eliquis is what you're going to see it referred to a lot. And you'll be giving Eliquis to a lot of your patients. What's nice about this is it has an antiplatelet effect, but we don't have to monitor it. So they can just take the medication and go on about their life, and they don't have to come in and get INRs done all the time. That is a #1 line of therapy for somebody who has had a heart attack or is highly at risk for a heart attack. Usually it's after they've had a heart attack that they'll put them on this stuff.
Bryce,
Yes.
super quick, can you say what INR stands for again?
International normalization ratio, I think. Let me look it up real quick. I know international and ratio I got right. I'm not sure if I got the other part right.
I think it's international normalized ratio.
That's it. You got it. International normalized ratio. And it's basically a test of showing the ratio of your clotting factors, non-clotting factors.
It's a standard for the PT, right? It's a standardized PT.
The PT and the PTT is mostly used in heparin.
But the INR is a standardized PT.
Yes.
Yeah.
Yes.
I think.
Oh, I'm sorry. Yeah. You're the my tongue just got lost somewhere. You're the pharmacology teacher. Yeah. So yeah.
We'll get there together.
Yeah, one way or another. We'll figure it out. But the important thing to remember is heparin, we use heparin in the hospital. We don't send people home on heparin. We send them home on warfarin. And if we can move them to Eliquis, all the better, because they don't have to do that. But in the skilled nursing facilities and in the hospitals now, they have a portable tester for INR, and it looks almost exactly like the blood glucose monitor. So we can now poke somebody's finger and get an INR within minutes, as opposed to having to draw a tube of blood and send it to the lab. So that's a nice thing now. And you will probably be doing some of that when you go to your clinicals. Why would they put a client on one over the other? That's a good question. I think maybe, Andy, you might be able to help me out, but warfarin is stronger. Whereas Eliquis, I don't think has quite the punch that warfarin has.
Yeah, I agree. And sometimes I think that they're more likely to use something like Eliquis or other antiplatelet agents when there's like risk increase related to like valve surgery or something like that. So that increases their risk level, but it's related to a certain event.
Yes.
Yeah.
The warfarin is stronger. They're more likely to bleed. And when we get into atrial fibrillation, when we talk about atrial fib, we'll talk, that's when we use warfarin and Coumadin quite a bit as well. So we'll talk more about that when we get to atrial fibrillation. In fact, usually when I've seen warfarin prescribed, it's usually been for AFib more than post-cardiac. Most post-cardiac people I've seen, they put on Eliquis.
Oh, so they wouldn't put like an AFib patient on Eliquis?
Pardon?
They wouldn't put an AFib patient on Eliquis?
That's a good question. I don't know. Most of the patients that I've seen in chronic AFib have been on warfarin. And I don't know if maybe Eliquis is not strong enough to counter. What happens with AFib is while your atrium is kind of quivering, blood can pool, and pooling blood can form clots. And I don't know if Eliquis is strong enough to prevent that from happening. But that's a good question. I'll look into that. Jot it down. Okay, no. The other cardiac drug that we're going to cover this week is nitroglycerin. And I probably already explained quite a bit about what that does. Basically, it dilates the vessels in your heart, allowing your heart to get more blood flow. More blood flow equals better oxygenation. In the hospital, we have big glass bottles of it. We can give nitroglycerin to patients, and we normally do. Cardiac patients are usually on a nitroglycerin drip, and that opens up the vessels to the heart, allows the heart to get more oxygen. Now, when people go home, they don't take nitroglycerin as a normal medication. The nitroglycerin is just for emergencies when they start having chest pain, when they start having angina, then they will take the tablet and put it under their tongue. If a patient ever asks you, how do I know if my nitroglycerin is still good? Because it's got a shelf life. I usually tell them, if you put the tablet under your tongue and you feel it tingle, the nitroglycerin is still good. If you don't feel that tingling, throw it away and buy another bottle. They're cheap. Like I said, they take it 3 times, 5 minutes apart. If after that 3rd time they still have chest pain, they call 911.
Is it safe for somebody that's prescribed nitroglycerin just to like try it to make sure that it's still good if they're not having chest pain?
I wouldn't. Nitroglycerin has a side effect. It has a couple side effects. One side effect is when it opens up all those blood vessels in your heart, it's also going to open up the blood vessels in your body. And when you open up your blood vessels in your body, what happens to your blood pressure? So you could take, if you have a normal blood pressure, you could take a nitroglycerin tablet, sit up, orthostatic hypotension, and pass out. Another side effect of nitroglycerin is it gives you a horrible headache. So I wouldn't sample it if I were you. Yeah, let the patient, and there again, if the patient's not sure if the nitro tablets are still good, throw them away and buy some more. They're really cheap. It's been out there, that medication's been out there forever. Well, we take a close eye on the expiration date on the little bottle. They're little tiny bottles about this big that are a dark brown because the sun will affect them. So they're a really dark brown bottle, and you'll see them in the hospital a lot. And always keep an eye on that expiration date. If they're expired, throw them away. And you might want to remember those 2 drugs there. Any questions on myocardial infarction? We'll talk some more about it when we get to ECG, or when we get to the electrical next week. We'll talk all about the ECG and how it detects heart problems. And then we'll talk about catheterization and cardiac surgery in week 10.
I have a question about going back to the coronary artery disease.
Yes.
So if risk factors are, some of the risk factors were obesity and then high fat diet, what about people who are obese, but they're trying to lose weight doing like the keto diet? Cause like that's a high fat diet, but they're losing weight.
Oh, you had to open that can of worms, didn't you?
Oh, I went there.
Yeah, you went there. Okay.
Have fun with that one.
I'm glad you asked, because that's something that I have studied a lot. There is a school of thought out there that believes that it's not the fat in our diet that causes our problems in our metabolism, but it's the carbohydrates. Carbohydrates elevate your blood sugar. Your elevated blood sugar elevates your insulin. Elevated insulin can cause an increase in, if I remember correctly, it's a risk factor in cardiac disease, because it will, trying to trigger my brain. It will help increase. It's a risk factor for plaque buildup and cardiac disease. Evidence of this is if you develop diabetes. Diabetes is a #1 risk factor for cardiac disease. So there are those that contend it's actually the high carbohydrates in our diet that contributes to the buildup of plaque in the blood vessels. And they say,
sorry, I'm wondering if it should be like a mixture of the both, like the high fat mixed with the carbohydrates together might just be a bad mixture.
Yeah, moving that's the theory behind the Atkins diet. I mean, it goes way back. Low carb diets have been around since the 1800s. There was a guy in the late 1700s that published a book called On Corpulence, where he put his patients who were obese on a mutton diet. So, I mean, low carb goes back that far. It's amazing. And like every 2 years, somebody seems to come, or about every 4 or 5 years, somebody comes out with another version of the low carb diet. Their contention is that fat is not really bad, but more research has shown that there are good fats and there are bad fats. For example, the kind of fat you get from pork and beef, and those seem to contribute to a high level of cholesterol in the body, whereas fat from, say, fish actually helps increase your HDLs while reducing your LDLs. And the omega-3s in the fish oil, I mean, fish oil, it's a fat. But the omega-3s actually help reduce your LDL and improve your HDLs. So I think when it comes to fat, there's a matter of there's good fats and there's bad fats. And you want to reduce the bad fats and increase the good fats. But by all means, I do agree with the school of thought that high carbohydrate diets contribute to heart disease. So limiting our carbohydrates while eating good fats and not bad fats is the best balance. Maya, you have a question?
Yeah, speaking about LDL and SDL, I was just wondering, so the SDL is the good fat, so we can consume any amount, like is there is a maximum level for that? If we have too much, it has any bad effect or no? I was just always wondering about that.
Yeah, HDL is supposedly a good fat. LDL is a bad fat. They're both lipids in our bloodstream. You don't really eat HDLs or LDLs. It's how your body breaks it down, and it's in your bloodstream.
Yeah, I mean, it also comes from the food, like you said.
Yeah.
In the fish or avocado and stuff like that, and the nuts. So if we consume too much nuts, fish, avocados, does it give any bad effect if its level is a little higher? I don't know exactly what it's supposed to be.
What happens is when you eat fat, your body breaks them down and fat gets broken down into lipids. And the lipids are, there's high density lipids and low density lipids. And that's where you get the HDL and the LDL. But yes, the good fats should improve your HDL and reduce your LDL. And the bad fats would do the opposite, increase your LDL and reduce your HDL. Does that make sense?
Yeah.
But we don't
What
really,
am I supposed
we don't really eat lipids. We eat whole fats, and the whole fats are broken down into triglycerides and lipids. Just like protein, when we eat protein, the protein goes into your body and it gets broken down into amino acids. Now,
Yeah,
there
but
are
my
people that
question
can
was-
take, you can take amino acid tablets, but most of us just eat protein and the body breaks it down into amino acids. Does that answer your question?
Yeah, but I was mainly asking, like, when we talk about the range, like SDL and LDL, how much we supposed to have, like, there
Oh,
is a range.
what the ranges are on the lab test?
Yeah, and then my question was like, if we have high SDL, it's not good for our health. But my question was, how about SDL? If we have too much SDL in our test above the range, what does it mean? That was my question.
I'm trying to look at the ranges. I don't have them memorized right now. But basically, from what I recall, HDL is the kind of lipid that moves fat through your body and through your digestive tract and basically keeps the arteries clean. Whereas the LDL has more of a tendency to deposit in your arteries.
Okay, thank you.
Does that make sense?
Yes.
And I'll put some more information on that on the announcements.
Thank you.
But I'd have to refresh my memory a little bit on that. But I know that they were saying that the HDL, the HDL moves stuff through your vessels better, keeps them cleaner, more efficient than the LDLs do. But I'd have to look at the exact mechanism for how that works.
I feel like a good way to remember which one is which is like if the HDL is the hardworking one, it's doing all that work, and the LDL is the lazy one that's just hiding. So they have to get rid of it.
I like that.
That's the
I
good
like
way.
that. That's a good way to do it. Any more questions before we move into peripheral disease? Okay. Moving on. Peripheral vascular disease. Now, basically what we're doing is just talking about arteriosclerosis and arteriosclerosis as it relates to the rest of the body outside the heart. And I'm not sure why they put this in the coronary chapters in the book, but they did. So we'll talk about it. But basically, we're talking about condition, and it usually affects the lower limbs. We stand up, gravity works, a lot of stuff collects down below, and we end up getting a lot of blood clots in our legs. And that's when we get like thrombosis of the leg. DVTs are the big one. And we'll move on with that. Mostly in the lower limbs is the thing. Here's a good example. You probably know this, but I'll go over it anyway. The heart pumps the blood through the arteries so that the blood gets to the body. But when it comes to the veins returning to the heart don't have a pump behind them. It's actually our musculature of our body that is what returns the venous blood back to our heart. So when you're walking down the street and your calf contracts, you basically squeeze the vein and the blood goes up the vein, and there's little valves in the vein that close and keeps your blood from dropping back down again. And that is how we get the blood back to our heart. It's our actual muscles contracting that squeezes the blood from our veins back to our heart. Now you know why we put SCDs on patients in the hospital. Those little stockings we put on their legs, and they squeeze and they relax, and they squeeze and they relax. That's because we're trying to get that blood to keep flowing out of their legs and back to their heart. Now, you notice when a person is standing up, blood has a tendency to pool. You know, gravity works, blood pools in the legs. And that's why the legs are the biggest victims of blood clotting, because this is kind of where the blood kind of sits. Now, PAD is peripheral arterial disease. That is when the artery is blocked, and that is different than peripheral vascular disease. Or peripheral, well, it's different from when the veins get plugged, because in order to keep the blood from flowing through an artery, something has to block that artery. So sores, infections, amputations, gangrene, things like this, it's very, very serious when an artery gets plugged, because the limb is not getting the oxygenated blood that it needs. And when that happens, you know, your capillary refill is long, the skin is white and pale, because it's not getting oxygen. If you get a sore or you get an infection of any kind, the infection spreads rapidly because your body's not sending the white blood cells there to combat the infection. If the tissue is totally deprived of oxygen, the tissue can die. And when you have dead tissue on your body, it can develop gangrene, and gangrene can kill you. I mean, that was one of the #1 causes of soldiers dying during the Civil War, was gangrene. And usually it may even have to result in you having that particular limb amputated. So if you have an artery that's plugged off by disease, it's a very serious problem. Very, very serious problem. However, as opposed to a vein being blocked, veins, usually you have enough peripheral veins in your body that if you're not getting your blood back to your body through a main vessel, it can get back around it through peripheral veins, but you still have issues, you still have problems, and that's where emboli and DVTs come in. You will have some paling of the skin, poor circulation, things like that, but nothing as serious as an arterial blockage. The real danger with DVTs, deep vein thrombosis, now that's when you get a thrombosis or a blood clot deep in the vein of your leg. We call it a DVT. The real danger there is if any of that should break loose, it can go to the heart, it can go to the brain, it can go to the heart and cause a myocardial infarction. It could go to the brain and cause a stroke. It can go to the lungs and cause a pulmonary embolism. That's where the real danger with DVTs are, is that you got a blood clot down there that can throw another clot and cause further problems in the body. And so that's what we're really afraid of when it comes to deep vein thrombosis or DVTs. Numbness, tingling, cracking, arterial pulsations absent below the obstructed area. This applies to both veins and arteries. This is the kind of, and you know, the tingling, you know, you sleep on your arm wrong and you cut out the circulation and you wake up and then your arm is like numb and you get that tingling back. It's really not fun. That's a sign of poor circulation. There are some additional things though that you will find with the DVT, a mild fever and pain in the leg. Now, because you're not getting the blood out of that leg as efficiently as you should, you're going to get swelling. You're also going to get tenderness in the area where that clot is present. There's a thing called Hohmann's sign. Hohmann's sign, a person is laying down and you take their toes and you push their toes toward their head. So you're pushing the foot upward. If somebody has a clot in their calf, they will feel severe pain. That's not used as much as it used to. I still use it occasionally. If someone is complaining of cramping pain in their calf, I may push up on their toes to see if they get severe pain, and I will report that to the doctor. Then they bring in the ultrasound and they look for clots. Never, never, ever, ever, if you think there is a clot, don't go poking around, don't go palpating, because if you do, you can actually break one of those clots loose and it will travel through the body. Now I'm going to go back here for just a second to show you something. Every once in a while, you hear of them talking about putting an umbrella in the leg. If somebody has a tendency to get clots in their leg, up here in the femoral area of the leg, they will put a little basket looking thing, kind of looks like this. And it's got a screen on it. And they actually put that in the vein so that when the blood goes out of the leg and back to the body, any blood clots that may be there get caught in this basket. So that is one procedure that they might do for people who are inclined toward DVTs. And this keeps them from throwing a clot to the heart or to the head or someplace like that. If you hear them talk about them putting an umbrella on the leg, that's what they're talking about. Never palpate a leg you suspect of having a clot.
Can I ask a question?
Sure, go ahead.
So on the quiz that, actually, I've got to answer this. I'll ask you when we're done.
Okay, that's fine. Arteriogram or venogram, that's where they actually take them into a radiology lab and they shoot a dye into the artery or the vein. And that dye shows where the blockage is. Ultrasounds are better because those are portable. They just wheel the machine up to the room. And there is a radiology technician who does an ultrasound on the leg and it will show where there's any clots. Now there's a test called a D-dimer. A D-dimer doesn't tell you if you have a DVT, it just tells you if you don't have a DVT. So if your D-dimer test, it comes up negative, it's likely that there is no DVT. But it's not really a concise test. You know, you really have to do the ultrasound to find out if you have any kind of blockage there. Medical management, bed rest, elevation of the extremity, some local heat analgesics. They might recommend some heparin therapy or oral anticoagulants like warfarin to help reduce the clotting. It does two things. Hopefully it prevents you from forming clots, but it also helps to break the clots down that are already there. Now, surgical management, thrombectomy, that's just where they go in, they cut open the vessel and they just remove it. Hopefully you don't have to go that far. Any more on that? Before I get into the drugs, are there any questions so far?
Okay, can I ask the question about the palpating clot? I was just going to write it down, but it's easier just to ask it. So on the quiz, the last question, I believe it was, I don't remember the exact specifics about it, but you would do all of this except, and then it had the palpating of the clot. But yet when I clicked on palpating of the clot as the answer, I got it wrong, even though the answer that popped up underneath it says never palpate for a clot.
Okay, probably something wrong with the test question. I'll have to go back and look at that, but I think you were right.
Okay, thank you.
Yeah.
I did send a message along with it, but I figured since I had you on here, I'd just ask.
Yeah, why not? So okay, clock question on the quiz. Okay, I'll check that out. Make sure I programmed it right. I might have programmed it wrong.
Thank you.
I think there's just one more thing I want to cover, and I kind of covered this a little already, but we'll just go into a more detail. You know how we're really hammering pharmacology now, because I'm beginning to find that in the clinicals and on the NCLEX exams, it's pharmacology that people seem to be having the most difficulty with. So we're trying to make it as easy as we possibly can to learn the drugs. And face it, if you're an LPN and you go to a skilled nursing facility, about half your time you're going to spend handing out drugs. So you really need to know your pharmacology well. Anticoagulants, they were back to heparin and warfarin again. Heparin, this will be given in the hospital. You'll be on a heparin drip. There will be what's called a heparin protocol, which is a bunch of sheets that tell you exactly how much to give. You have to give a bolus of so much heparin. Then you give a drip of so much heparin, so many drips per minute. And then we frequently do PTT tests on them to see how, if we're at therapeutic dosage. And usually PTT, prothrombin time, is how long it takes for the blood to clot. And 60 to 100 seconds is what we're shooting for when we are treating somebody with heparin. Now, you and I walk around the street, 25 to 35 seconds is our normal time for it takes us to form a clot. We want to extend that time. We want to reduce the number of clots they have. So that's basically what heparin is doing, is it's decoagulating you, is what we call it. There again, that's the purview of the RN. I don't believe LPNs can do heparin, but you will be exposed to it and you want to look for signs and symptoms and problems and stuff. So it's good for you to know the drug anyway. Oral anticoagulants, then they get out of the hospital and they go home or they go to a skilled nursing facility. This is the drug you'll be dealing with. Someone's on warfarin or Coumadin, keep an eye out and make sure they're getting their INRs done. Like I said, you probably will monitor them using a portable device in the skilled nursing facility, or even in the hospital. They probably have the portable device, and once or twice a week, you just do an INR. Remember, you want them between 2 and 3. That's easy to memorize, right? It's easy. You already know it. You know it now, right? You'll never forget it, right? Right? Okay. And of course, there again, going back to Eliquis, it does not require the INR, which is nice. Okie dokie. What else do we have? Nursing management. With DVTs and any type of arterial or venous blockage in the periphery, you're going to deal with pain management. You'll probably be using a lot of analgesics, oxycodone, hydrocodone, the opioids. Hopefully you can manage it with just Tylenol or ibuprofen, but if it gets really serious, they'll bring in the opioids. Another nursing diagnosis, ineffective peripheral tissue perfusion. When you have that, you have to be careful that you always check their extremity, check their capillary refill, check the temperature. If they're restricted flow of blood, their limbs are going to be cool to the touch. and CMS. CMS is color, movement, and sensation. When you start clinical 1 and start doing head to toe assessments, you will do CMS on both hands and both feet. You want the color to be pink. You want them to be able to move it, and they should feel the sensation when you touch it. CMS. Always check the peripheral capillary refill and temperature and their CMS. That's very, very important if you are suspecting any type of perfusionary problems. If there's a suspected DVT, then we measure the calf, see if the calf swells. And of course, peripheral pulse. If you don't feel a pulse there, you're in real trouble. So, something to remember. Any questions? I think we're done. How'd we do? Probably did a full hour, didn't we? Yeah, we did. A little more. Whoop, that's it. I will stop the share. Any questions on any of the material that we have covered in this session? Going once, going twice, I will stop the recording.